Good afternoon, everybody. I'm so excited to be here with all of you. My name's Amanda Lewis. I'm the director of the Institute for Research on Race and Public Policy here at UIC. For those of you who don't know us, we work to increase society's understandings of the root causes of racial and ethnic inequities, and to provide the public, policymakers, organizers, practitioners with research-based policy solutions. I want to thank today the UIC School of Public Health, and particularly Antonia Lewis-Reese. Did she leave? No, maybe she's not here. Anyway, she's been hugely helpful. You can tell her we said thank you in helping us. But thank the school for co-sponsoring this event and our other co-sponsors. We want to thank all of you for joining us here in person. We have lots and lots of folks also online for this really important conversation about the history of organizing for public mental health services in Chicago and Illinois, and what it means to train a workforce and build a mental health ecosystem that can respond to people's needs. A couple of notes today about our event before we get started. We are recording this event, and once we process it, the video will be posted on our website. Captioning is being provided both in person and online. We have an amazing lineup of panelists that will be introduced shortly, and after they speak, there will be time for your questions. For those online, please use the Q&A function on Zoom at the bottom, as we're using the chat today only for links and announcements. And for those in person, we'll ask you we'll bring a mic around or something like that. We'll make sure that you can be heard by everybody. With that, I want to introduce Dean Wayne Giles to say a few words. Dean Giles has led the UIC School of Public Health since 2017. Before that, he spent 25 years at the Centers for Disease Control and Prevention, where he led the Division for Heart Disease and Stroke Prevention, Division of Population Health, and the Division of Adult and Community Health. I've never asked if you did all those things at the one time, which I've always been curious about. We are so glad he's here at UIC and been here. He's a wonderful partner of ours, and we always appreciate his collaboration. So with that, I'll turn it over. Thank you very much.
Thank you. It's great to be here. Thank you for that really nice introduction, Amanda. It's always great to partner with IRRPP, partly because you all put together such great documents that are so important for the communities across Chicago, do such great cutting edge work. And in addition to that, you put on some amazing events, much like I think we're going to hear from the panelists today. So on behalf of the School of Public Health, it's great to have the esteemed panel with us today, and also the audience, both those of you. It's great to see a room full of people, so it's great to see that, along with all the people who are on Zoom as well. So it's great to see all of you, and I hope we can have an engaged conversation where we can all learn today as well. You know, since we're public health, we're very focused on life expectancy and the life expectancy gap. And as you all know, across communities in Chicago, we see between 10 and 15 years difference in life expectancy, depending on where you live. And one of the most important determinants of that difference in life expectancy is mental health and well-being. And I think really being able to prevent and treat mental health conditions in a more holistic and more humane way is part of what we need to do if we're going to address that difference in life expectancy and really have an impact on the well-being in the communities where we all live across the city. And so I'm really looking forward to learning from the panel about all of the great community organizing that has occurred around this process and sort of how we can all collectively move forward. This, I think, is a really exciting time for us in the city to really embrace health and well-being, and particularly mental health well-being. I also want to just acknowledge the Department of Medical Education and the College of Medicine, the Policy, Practice, and Prevention Research Center in the School of Public Health, along with my boss, Dr. Barish, in the Office of the Vice Chancellor for Health Affairs, all of whom were co-sponsors with the School of Public Health on today's event. And finally, it gives me great pleasure to introduce to all of you an amazing colleague and partner, Dr. Branicki Floyd. She is the Associate Dean for Community Engagement in the School of Public Health, along with the Director of the Collaboratory for Health Justice in the school. It's sort of our community engaged arm with the school. She's a great scholar and colleague as well. And with that, I'll turn things over to Dr. Floyd.
Hi, everyone. Welcome. Thanks for coming. We have a really exciting panel for you all today. And I'm going to introduce our great panel. And then I'm going to turn the mic over to each of them to share some great things. So first up, we have Arturo Ferreira. He's the Deputy Director of Health and Violence Prevention at the Brighton Park Neighborhood Council, as well as a leader of the Collaborative for Community Boldness in their research and documentation of inequities in mental health services for low-income communities in Chicago. Arturo will be talking about the history of mental health organizing in the city today. And then next we have Jessica. Hi, Jessica. Jessica Camino, who is a mental health policy analyst at Access Living. Jessica will be discussing how we can better implement the CESSA, the Community Emergency Services and Supports Act, which Governor Pritzker signed into law in 2021. Its goal is to dispatch mental and behavioral health support to people in mental health crisis in 7 states. And then next we have Rosanna Rodriguez Sanchez. She is the Alderwoman for Chicago's 33rd Ward. Originally from Puerto Rico, Alderwoman Rodriguez Sanchez has been a lifelong advocate and organizer for public health education, labor rights, and the well-being of youth and families. Treatment Not Trauma was first introduced to the City Council by Alderman Rodriguez Sanchez in 2020, and she's going to talk more about the legislative struggle to address mental health today. And then last but certainly not least, Catherine Bocanera is an assistant professor in UIC's Jane Addams School of Social Work. I do what you do. Social work. She has over 19 years of experience with community mental health, community violence prevention, and criminal justice reform. Today, she's going to address the research and what it means to train a workforce of public health workers, counselors, social workers, and mental health professionals to serve the goal of the Treatment Not Trauma campaign, which is a statewide CESSA legislation. So I'm going to turn it over to our chairman.
Thank you. It's an honor to be here. Definitely appreciate the opportunity to speak and represent the many voices that have been part of the mental health movement and all the advocacy that's gone in for decades to get us to where we are today. It's also an honor to share the space with esteemed colleagues and co-conspirators in the struggle. I remember our work, Catherine and I, we were just trying to assess what mental health access looks like in Little Village and thinking about again, the impacts of the inequality that we see when it comes to mental health access in Chicago. So I'll tell my story of how we got here today, but of course, my colleagues here and of course, will be able to fill in a lot of the gaps and give us a fuller picture of how advocacy partners with research, partners with political power to make the difference that we see today. It's not been an easy road. And as unfortunately Cheryl Miller and Stop Chicago is not able to be here with us today, but they also laid the groundwork for where and how we were able to identify this investment when Mayor Daley and Rahm Emanuel started closing public mental health centers in Chicago. It's often surprising for people to hear that Chicago once had a robust system of public mental health centers, right? This is part of a landscape that has been stripped away and disinvested in. That landscape, again, leaves us with 5 centers at the moment, and all credit goes to the people who fought to keep those centers alive, that we still have 5 centers as a result of the struggle. So, you know, Cheryl Miller represents STOP and also mental health movement. These were advocates who had to put their bodies on the line to actually lock themselves into the space in the Woodlawn Center to bring attention to why closing these centers and kicking people out of services would have real life consequences. There are advocates who have lost their lives as a result of those political decisions. So, as an observer, as a licensed clinical social worker myself, as a lifelong Chicagoan, being witness to that, being present and supporting, as a social worker, it was important for me to think about my role and my place in supporting advocacy work. So again, as I mentioned, Dr. Bocaneda and I, we're working in the village at the time and rethinking and dealing with the upstream consequences of that decision, right? Our wait lists moved. We had 3 month wait list that went to 6 months after the closure of public mental health centers and upwards of a year. We were trying to create programming that offers free mental health services in, again, Chicago's west side, Chicago's southwest side. And no matter how many clinicians we hired, no matter how much we were able to quote unquote expand the program, you never fully expand to meet the overwhelming need that is as a result of this investment that's gone on for generations, right? So that took Catherine and I and others into the space of research. We felt that the way to be able, and I feel like I'm speaking to the choir in your class of public health, right? But to be able to document the need and have the numbers to actually talk about what the barriers to care was a very key and pivotal moment for us as a coalition. It was through that research that we started Collaborative Community Wellness, and what we were able to document was the enormous disparity when it comes to access to care. Right, the narrative that I heard as a social work student in the social work space was that Latinos, Mexicans, people of color do not access mental health services because of stigma. That was always a narrative, right? And then we actually went out and surveyed community residents of color at Chicago West Side, Chicago Southwest Side, and we found overwhelmingly that people were actually desperately seeking mental health services. There wasn't actual awareness of why depression and anxiety and stress and PTSD was having an impact in the lives of themselves and of their loved ones. The biggest barrier actually was that those resources were not available, that those centers had been closed, that people were uninsured, that people could not afford the $150 sessions, right? The costs, right? This is what was the biggest barrier to care. And so that started for us not only a research initiative that was able to quantify the need, and also paint a picture of what Chicago really is, which is, the Dean alluded to it earlier, right? These health disparities make Chicago a tale of two cities, right? There is parts of the city that have an abundance of resources, and then there's the rest of the city that does not. And that does have real life consequences for people. So when you started looking at the data, you started seeing that there is an overwhelming demand for services. When you actually ask people, if they wanted to receive public mental health services, and this is reflective of a citywide survey that we did, 94% of Chicagoans said that yes, I would absolutely benefit from therapy services for myself or a loved one. When asked if they would seek out services at a public mental health center, 90% of Chicagoans said yes. Right, so again, I'll challenge you, and this is a room full of researchers, to come up with another question in which we get 90% of Chicagoans agree on. Right, but accessing public mental health centers for free mental health services is, surprise, very popular. It's very much a common sense public health policy, but one that faced a tremendous amount of resistance. And so for the last 4 years, and we'll definitely speak to this, being able to make the case for why reinvestment in public mental health centers was absolutely necessary and the right thing to do was unfortunately an uphill challenge. And what was so eye-opening for many people was that it was no longer an issue of money. The city was overwhelmed with the amount of federal relief that they were receiving, $2 billion worth of federal relief. And yet we had a mayor who ran on a campaign promise, in this case, candidate Lightfoot, for $25 million to reopen public mental health centers. And somehow there was still not a political will, even when you're drowning in federal relief that should be going to reopen these structures of care. So again, I keep talking, I know I don't want to talk on mic, of course, but there will be an opportunity to really impact this. But I guess I'm here to introduce how the combination of the research, the grassroots organizing, the political movement organizing that also led us to have a new mayor that came on the heels of referendum votes that passed with over 90% response rates that were approving reopening public mental health centers in order to build a public care infrastructure that would be necessary to create non-police crisis response systems citywide in the city of Chicago. Again, these are policies that have been implemented in other cities, but faced severe resistance in the last 4 years. Now, for the first time, we will have an open working group to establish how we will make this a reality in Chicago. And again, that came because of all the work that has been done throughout the years by advocates, by consumers, by students, by people in the community, by all of us here in Chicago who want better policies that reflect the needs of our community in order to make a difference for those that we care for. So I'm excited to get into this conversation today and look forward to hearing from the other speakers as to what that would look like and how we look to implement that in the next 2 years.
All right. Hi, everybody. My name is Rosana Rodriguez. I am the elder person of the 33rd Ward, and I am now the chair of the Committee on Health and Human Relations for the Chicago City Council. I can talk a little bit about how we got to this place, particularly as it pertains to treatment of trauma. I think that telling the story is really important. I wrote alongside my chief of staff at the time, treatment of trauma. It was later baptized treatment of trauma. At that point, it was the crisis response and care model. And in all honesty, we wrote that in response to the murder of George Floyd and the protests that we were seeing on the streets. And we have to say that out loud every time that we have a chance, because that was a moment of reckoning around why we need structures of care instead of putting all of our resources into punishing people and killing particularly Black people on the streets. And as a member of the city council, I really thought that we had a responsibility, an institutional responsibility towards the people of Chicago to take a step to change that. So it was definitely in response to that moment. Of course, being from Chicago and having been an organizer for a very long time, I knew that Chicago had been fighting to reopen the mental health centers for a very long time. So I called Arturo and I said, what do you think if we merge these two ideas? We continue to fight to reopen the public mental health centers, but we think about the mental health centers in a different way. How about we start creating crisis response systems that come out of the centers so that we can actually have mobile units out in the communities helping people who are desperate for care and attention. And Arturo agreed, and we got to work, and then treatment of trauma was born. When I came into the council with this idea, people were absolutely not happy. Nobody was happy. Nobody was happy with me. Of course, it became a defund measure, and that's what everybody was calling it. But we stuck with it, and we just kept saying, we need this. And as Arturo said, the mix of opportunities for research, the organizing, plus a block of progressive elders that were also trying to push for it, helped us move the needle. We also joined forces with AFSCME because I think that this is also a matter of worker justice. One of the biggest challenges that we have in the city of Chicago and everywhere in this country is the privatization of care. And we know that most of the care work has been delegated to nonprofits. When we do that, there's a lot of problems, starting with, how workers get paid and the conditions in which workers have to perform their jobs and are tasked with caring for people in our communities. But then there is also the lack of transparency around how are we providing these services, what counts as actual services. So we started challenging the administration a lot around those things. The mayor at that time, of course, Lightfoot had promised that she was going to reopen the mental health centers, but then immediately she decided to do the opposite. And most of the money that came in after COVID was sent to nonprofit organizations. But AFSCME was a good ally to us because at some point they also started pushing to make a lot of the position that we need, the positions that we needed public. And we were able to make some progress there. And during the last term, we were able to increase the staffing at the public mental health centers to the sorry, my English is failing me right now. The biggest increase in staffing for the mental health centers during the last 4 years. And I think in the last 10 years. So we were able to increase the staffing by, I think, 25%. So all of this happens because we organized. We organized together. We had people inside. We have an inside-outside strategy. We were able to do the work inside, and we were able to do the work outside. As Arturo mentioned before, we were able to put the treatment no trauma issue on a referendum that went into 3 different wards, the 33rd, the 20th, and the 6th. And the average was 97% of the vote saying that they agree that we should actually send behavioral health workers and care workers to deal with mental health crisis instead of police. And that's a pretty incredible survey right there, because then it served as the platform for Brandon Johnson. Then Brandon Johnson decides to run. He sees these numbers and it's like, yeah, this is what we're doing. And he ran on treatment no trauma as one of the main points of this platform, and he won. And now we are building this together. In terms of how this impact my ward, we have a lot of people with mental health conditions. We have a lot of homeless people who, you know, neighbors are going to call our offices for. And right now, the only thing that I have is the nonprofits that are taking money from the state through CESA, and they don't come out for anything. They will send me emails saying, we don't know if we can do that. You're like, well, can you drive by and like just see if these people need anything? Well, we don't know if it's too risky. So at this point, I feel like it is very important that this work is delivered through public means. I think it's really important that we build it in a way that safeguards worker justice, that the people that are tasked with caring for our communities have decent salaries, have pensions, just like the police does. That we're not even asking for much more. We just want the people that we are tasking with keeping our communities safe through care. We want them to be able to have exactly the same that we offer to other first responders. And we really believe that it is completely feasible to build it. One more thing about treatment no trauma, we want to be able to create 24-hour walk-in crisis centers. And we believe that this is a really important component of the model, because you can definitely have mobile units that are going to come and intervene and try to de-escalate and take care of people. But if you don't have a place to transport, that definitely becomes a huge issue in order to be able to provide proper care and develop an aftercare plan and be able to follow up with that person. So we have been advocating to make some of the mental health centers that are going to be reopened walk-in crisis centers that are open 24 hours. And I always mention this case that I don't know if people are familiar with, but I want everybody to remember. There was a woman called Irene Chavez. She was an Afro-Latina queer veteran. She had PTSD after, I believe it was 2 tours in Afghanistan. She was in treatment. She had a therapist. She went out one night with her friends and she was not having a very good time. She ended up in an altercation with the bouncer of the place where they went to hang out at, and the bouncer called the police on her. She was unarmed. She did not represent any sort of danger to anybody. The police got there, they put her in a squad car. The whole time she was telling everybody around her that she needed to see her therapist, that she was undergoing an episode and that she needed help. They took her to a police station. They put her in a holding room. The holding room didn't have a visibility. They couldn't see her. When they came back to check on her, she had taken her own life. She should never have been in a police station. And she let everybody know that she had no business being in a squad car. She did not need to be in a police station. She needed help. And she said she needed help. And she did not get help. And we are responsible for that. So one of the main things that we need to accomplish through treatment of trauma is make sure that we have a place to transport and that we can help people at any time of day and night to make sure that we're saving lives. And that's what we're going to be working on. Thank you.
Thank you, everyone, for your time. My name is Jessica Jimeno, and I am the Mental Health Policy Analyst at Access Living. So I'm going to talk about, as Nikki said earlier, CESA. That's the Community Emergency Services and Supports Act. And I'm going to share with you three things. The first is why I got involved in mental health advocacy. Second, how CESA came to be. And third and finally, how you could get involved. So the Cliff's Notes version of my advocacy, it sounds cliche, but lived experience and loss brought me here. I have bipolar 2 disorder. I've had it my whole life. I was diagnosed at 18. I've lost people to mental illness. And before Access Living, I did a lot of mental health advocacy through writing and speaking. You could see my work on my blog of 11 years called Fashionably Ill. I write about surviving pain with style and humor. I'm most known for my TEDx talk, How to Get Stuff Done When You Are Depressed. And like a lot of you, I've had bad experiences trying to access healthcare in this country. And so healthcare equity is very important to me. I want to help change the system. So last year I got my Master of Public Policy and Administration at Northwestern. And this summer I started working for Access Living as their mental health policy analyst. Since 1980, we at Access Living is a center for independent living. And since 1980, we have successfully championed the rights of people with disabilities in housing, healthcare, transportation, and education. Our ethos is nothing about us without us. And Access Living wrote CESA. So how did CESA come to be? Well, for those of you who don't know the story, in 2012, there was a 15-year-old boy named Stephen Watts. He had autism. He was Black. And his family was having a hard time getting him to go to school that day. He was having a mental health episode. So his family called his doctor, and the hospital suggested that they call the police to help transport Stefan to the hospital. And so that is what the family did. Stephen Watts' family called the police, and 4 Calumet City police officers came to their house, and they shot Stefan. He died. And as we know, altercations with the police or interactions, even when they're called to help, are more likely to turn fatal if the person has a disability, if they are Black or another racial minority. And in this case, Stephen Watts both had a disability and was Black. And so the community was angry about this tragedy, this injustice, and so people organized. And that's when Access Living wrote the Community Emergency Services and Supports Act. They had the vision that people in crisis would be able to get access to appropriate mental health supports in their community. And while Governor Pritzker signed CESA into law in 2021, it is a long journey. The bill has not been implemented yet. The tentative date for implementation is June 2024. And so how does CESA work? Well, how it should work, right? So if your family member fell and they broke a leg, you would probably call 911 and you would expect that a doctor would treat your loved one, not a police officer. And you should have the same kind of care in a mental health crisis, just like you do in a physical health crisis. And so what we envision for CESA is if you or a loved one was having a panic attack, you could call and be connected with mental health supports in your community. That's how it should work. So as we know, advocacy is a marathon, not a sprint. So this is the goal of CESA, connecting people who contact call centers to specialized mental health care. So the call center is supposed to dispatch mobile mental health relief providers. Who are these mobile mental health relief providers? They're licensed clinical social workers, they're peer professionals, mental health advocates, they're mental and behavioral health providers in the community. They spend concrete time with the individual in crisis and give them specialized care. And thankfully, we know that mobile mental health relief is not merely a dream. It is a reality, and it is happening in some parts of the country right now, like Olympia, Washington, Denver, Colorado, Eugene, Oregon, Atlanta, Georgia, and Dayton, Ohio, to name a few. It's also happening in some parts of Illinois. So Aruka, for example, provides mobile mental health relief in Ottawa, and NIAP, the National Youth Advocacy Program, has a sophisticated mobile crisis response team. They provide services in Peoria, Sycamore, Rockford, and some parts of Chicago. They have a 24/7 call center, on-site skilled physicians who will meet the person in crisis wherever they are, regardless of their insurance status. But the job isn't done yet. What we need is for everyone in Illinois to be able to experience the benefits of mobile mental health relief, regardless of where they live, regardless of their insurance status. And this is the goal of CESA. We know that if we work together, we can give all Illinois citizens this relief. And so if you want to get involved, I encourage you to attend. There's Access Living has bi-weekly coalition meetings every other Wednesday night. You can join us on Zoom. They're virtual meetings, so I encourage you to attend those meetings if you want to learn more about how to get involved in CESA. My business card is there. You can talk to me after the panel is over. So in conclusion, I just want to ask you for your help. Help us achieve the promises of CESA. Thank you.
Okay, I'm the last person before we get to the Q&A, so I'll try and go. I'll try and be. Okay, there we go. So I'm Catherine Bocanegra. I'm an assistant professor at the Jane Addams College of Social Work at UIC. So I'm just down the road on Harrison. And I also want to thank IRRPP for the invitation because I was your faculty fellow 2 years ago. And I want to thank you for the support that you provided in some of the research that I'll be discussing today. So my background is in community mental health, a long history of troublemaking with Arturo and community violence intervention. And I think what we're talking about today is at the intersection of those two issues, because we know when behavioral health needs go unmet, that violence is the manifestation of unmet needs. And so what I want to just comment briefly on are the implications for the workforce that's going to be providing this critical care for Chicago's residents. I want to highlight, and I'm the nerd that has notes here because I really want to accurately represent the excellent research that the Collaborative for Community Wellness continually produces. So they have a website, they have annual research reports. I want you to all check them out. So I want to highlight some of the excellent work that the Collaborative has done to highlight some issues related to workforce needs as we consider the expansion of public mental health services in the city. So in 2022, the Collaborative surveyed 652 residents of Chicago, asking them what types of support should be available to individuals experiencing mental health crises. And so 77% stated that they wanted a mental health professional to respond and not law enforcement, which has been repeated throughout all of our esteemed panelists. But what really struck me is that 94% of the survey respondents said they wanted a peer support specialist as part of that crisis response team. So I want to dwell on that for a second. A peer support specialist, even though I'm assuming most of you know what I'm referring to, is somebody who has that shared experiential wisdom that comes from having lived through a parallel or similar life experience. So that could be living with a mental illness or being a family member of somebody with a mental illness or a substance use disorder. And so the 94% of survey respondents in 2022 said they wanted a peer support specialist, somebody who could relate to and connect to as part of that crisis response team. And then lastly, 81% stated they wanted wraparound services. So not just their mental health needs, but they don't want a fractured or splintered care system. They want to be able to have all of their needs met by the team who's responding to them. So what I think these findings signal is that when community members are in mental health crisis, they want to be able to access support within their community with someone who they can relate to and connect to, who understands where they come from, and that they don't want this fractured and splintered system of care. And so one could say that, hey, we already have this in the city because under the previous administration, we had trauma-informed centers of care, which was these grants that went out to nonprofits. We have our hospitals, we have our ERs. However, the research of the collaborative is really demonstrating that existing efforts are completely insufficient and out of alignment with what community wants. So research from 2021 from the collaborative, you can tell I'm a huge fan, they do great work, suggests really severe deficiencies with the trauma-informed centers of care. So these are, again, grants that went from the city to nonprofits. From an initial evaluation of those centers of care, 17% of the surveyed organizations did not serve undocumented residents, 25% did not serve those without insurance. And so one could argue that our Chicago residents who are in greatest need of care are not being able to have their needs met within the existing systems of support. So what the research from the collaborative signals is that there's little public oversight and accountability related to the funding of nonprofits and the privatization of care, and investing in and that investing in public systems of care will actually maximally impact and address the mental health and behavioral health needs of Chicago residents, and also hold us accountable for developing systems of care that are responsive to their needs. So when I talk about violence reduction, which is split between these two worlds, one of my colleagues, Tenny Gross at the Institute for Nonviolence Chicago, often says we need to invest in a robust civilian infrastructure for community safety and wellness and access to 24/7 crisis supports and publicly funded systems of behavioral health care are part of this essential equation. So with the reopening of the mental health centers, it's imperative that we think now about how these services will be structured and the workforce involved in providing this really essential care, our first responders. For this reason, Governor Pritzker launched actually a behavioral health workforce education center in partnership with UIC. My college is a secondary hub supporting data collection and training initiatives. And there's an annual $5 million investment in the training and expansion of the behavioral health workforce. The co-director of the center, who was one of my colleagues at Jane Addams, Sonia Leathers, said that she recognizes that effective services are needed in a range of traditional and non-traditional settings, which I want to lean into right there. And this is also where I want to bridge into my area of research, which IRRPP, I'm really thankful again for your support. So in my research and community work, my focus has always been on individuals whose lives have been significantly altered by violence, and identifying supports and strategies to establish safety, wellness, and meaning in the aftermath. And so I've done work with family members of homicide victims, of criminalized survivors, of survivors of structural and systemic violence, particularly those who've been incarcerated for extended periods of time and who are reintegrating back into their communities. And I can tell you that they are at the epicenter of what we're talking about today. Trauma is a result of relentless exposure to violence that stems from systemic racism and structural disinvestment. And so from being in proximity to people in communities who struggle with these issues, I want to just briefly share what they have taught me about what works in addressing trauma and disrupting cycles of harm. So what they have taught me is that most formal systems of support fail to address the needs of survivors of violence and trauma. And this includes nonprofits, and it can include city and state level efforts. In our conversation today, we examined the limitations of insurance-driven behavioral health services, and that even if those services are accessible, what I've learned from individuals who are at the epicenter of trauma and violence is that these services are often provided in culturally incongruent and even hostile settings that are hamstrung to a diagnostic framework that limits the care that's provided to them. I've also learned that individuals, so the second thing is that individuals who've been disproportionately affected by trauma and violence will continually first seek support from someone who shares their life experience. And I want to share briefly the example, because we've been sharing stories of people who are at the center of our hearts related to this issue, of an experience I had with a young man named Carlos. Recently, after I had graduated with my MSW and I was freshly licensed and thought I knew a lot of things clinically and thought I was an expert, and a juvenile probation officer called me and said that she wanted to refer this client to me because he had just been shot in the back and had a newly a surgical colostomy bag, right? So he was no longer able to use the restroom as you and I do, and that he had suffered some family trauma. And she's like, he really needs to talk to somebody. And so literally for 3 months, this young man was being driven to my office by a probation officer and said, nothing. We would play card games, we would do checkers. I did anything to try and build rapport, and he was completely frozen and blocked me off. And then I thought, okay, he needs somebody who he can relate to. And I again tried all of my outstanding clinical skills that I got from all of my licensures and degrees and whatever. And I called a community violence intervention worker from the neighborhood, or a street outreach worker, somebody who worked with young men and women who are involved in the streets. And I said, can you just come and meet this young man, and maybe he'll want to follow up with you. That was the whole point, is that maybe he'll have a number that he can walk away with. And in 30 minutes, this outreach worker did more than I had been able to accomplish in 3 months of doing, all my sophisticated clinical interventions. And he literally asked this young man 3 questions about where he was from, how's his family doing, what's he been through. And he went on to disclose that not only had he been shot in the back and was having a lot of trouble with his colostomy bag, that his brother had been recently murdered. He never disclosed that to his probation officer or to me. His brother had been dragged out of the house because he was a suspect in a homicide case. He was dragged out of the house in his underwear, detained in a police station, and 20 minutes later, the officers came out and said that he hung himself in an interrogation room. Again, he was dragged out in his underwear. That his mother was a survivor of intimate partner violence, right? That they were precariously housed. And so all of these things came out in a matter of 30 minutes, all right, sitting with somebody who they felt that they could relate to. And so I want to emphasize that creating a pipeline of credible messengers for this workforce is as incredibly important. And then the third thing I want to emphasize is that we need to take care of our frontline workers, which I'm so thankful Alderwoman Rosanna highlighted. Those on the front line of addressing violence and trauma are often, they're taking on the burden of healing others while they're negotiating their own past and current traumatic experiences, and it compromises their own wellness and safety. I learned through my research with street outreach workers that actually their employment experience is part of their current trauma. And it often comes from feeling underpaid and undersupported and even criminalized and marginalized within their own workforce because they're a peer support specialist, right? They're seen as less professional. And so I want to wrap up by highlighting the last one of the most excellent recommendations from the collaborative in their white paper that they released in July that they want to develop a community care worker corps that is focused on trust building and direct service delivery that makes central the use of non-professional mental health workers alongside professional providers. And I want to encourage us to think about how they're recruited, how they're trained, how they're supported, and how they're cared for as they lead us in this really important direction.
Please give another round of applause for our guests. First off, I want to thank you all for not only being here and lending your expertise, but sharing such important and critical stories to help us fully understand what this looks like in our communities, especially communities that we often aren't members of. So thank you for that. Before I open up the questions, you guys can start thinking about your questions. I know you got questions. I'll get us started. Actually, I have a lot of questions, but I'm going to just sort of start off with just one question in particular. And this question is for Catherine. Given your research, your work with the criminal justice system, what role do you think that the criminal justice system can play in addressing the mental health crisis in our communities? Just how can they reimagine other solutions in addition to complement what we're talking about with the campaign?
I think I might turn the question on the head and say they should have no role whatsoever. And we know that our Cook County, you've heard, everyone in this room has heard this, our Cook County Jail is our largest mental health provider and facility in the state, nation, I don't know. So that is not what, people should not be punished for being unwell. And so they should have no role in it whatsoever. I didn't talk about it right now, but there's a separate area of research that I do is on disrupting that community to prison pipeline for those with unmet behavioral health needs. And a lot of it is addressed in the Treatment Not Trauma campaign. And so I think that's the most succinct way I can answer.
Thank you for that. That's solid. Before I go into any other questions, does anyone have a question from the audience or anyone from Zoom? Yes. Should we just sort of? Thank you, Amanda.
Okay, is this working? Okay, it's working. Hi, everyone. My name is Elena. I do work really closely with Arturo. Dr. Bocanegra is one of my former social work professors, and I help Rosanna with her social work homework. She's also an NEIU social work student. And so I'm going to choose a question that Arturo and Rosanna have not heard 5 billion times. But one thing that Dr. Bocanegra mentioned is also something I care about a lot is thinking beyond using the DSM and the limitations of diagnostic criteria. I'm no longer a student, so I can say this, but there is no science in the DSM-5, which is the diagnostic tool you have to use so you can bill insurance and get paid for what you're doing. There is no science in that book. It is all based off of bullshit and vibes. And so sort of my question, I think, for any of you can take this is, under the public sort of system that we're trying to build, would there, if we truly have a public sort of publicly funded, not tied to insurance system, does this mean that the workforce in those centers can just completely divest from the DSM?
Yeah, so very important question to ask, right? Because we don't want to continue to institutionalize people who, again, are being harmed by disinvestment, who are being harmed by structural and systemic failures in our society. One of the things that we've envisioned, and I appreciate Dr. Bocanegra flagging the importance of the community care corps. Treatment of trauma essentially is a three-legged stool, right? We talk about, and we've talked a lot about the public mental health centers as providing the supportive care, the continuing care that people need, so we don't cycle back into crisis. The crisis response, right? Again, having peer support, paramedics, health workers, community health workers, the clinicians, people who are trained to support people in their moment of crisis. Very importantly, we also want to be proactive. We want to engage people in a way that can assess their needs without, as Elena very clearly emphasizes, right? Without having to diagnose anyone, right? You're able to assess people's social and emotional needs in a way that's proactive to prevent crises from happening in the first place. So having a proactive community care core that is very much embedded in community, that can identify and be engaged proactively in the people and the families that need that intense support is as much part of creating crisis response as the actual crisis response teams themselves, right? We want to be proactive and engaging people. And so that will look very different than what we're currently dealing with, right? We don't want to engage in any way people who are not trained to support mental health needs or social needs. But we want to think about radical solutions. You know, we look to Atlanta and other cities who are responding to people who are otherwise would be charged with shoplifting with a caseworker, with somebody who could be supporting people with their basic human needs. Survival crimes are a thing. They make up a big portion of our Cook County jail system at the moment, right? So if we can have somebody engage and support somebody who is stealing bread or diapers from a local pharmacy and find out what's going on in their lives, to be engaged and provide the follow-up care and visit them on a frequent basis, that is public health, right? That is, and will prevent future criminalization and institutionalization of people who are in need.
Hi, everybody. My name is Joel Novak. I'm not a researcher actually, but I am a trauma nurse. So I'm one of the frontline workers, and I see, you know, the effects of all the stuff that was discussed in the panel. I'm wondering if within treatment, not trauma, and we all know that the provision of like consistent shelter, how that really affects people's mental well-being and or lack thereof. And you know, especially in the current period, many shelters are beyond capacity, and you know, it's a sign of a crisis that doesn't really show any sign of really lessening anytime soon. I'm wondering if there's provisions that connect people to consistent housing and shelter, or that's been planned or discussed.
So we're doing everything at the same time, all of it. Definitely the idea of matching people with housing would be part of the case management work that should be done in the mental health centers. As a policy maker, we are also working on how do we make sure that we have the housing available, because one of the things that we know right now is that we don't have that housing available. So we have to work on both. We can definitely have plans to have case workers, making sure that they are connecting people with the resources, but we have to create the resources to be able to match people to them. And we are working on both. You are probably aware of the Bring Chicago Home ordinance and how it is going to be brought to the voters in the next election. It is a tax on mansions. It is a tax on properties that are over $1 million in order to create a constant or a sustainable revenue stream to be able to provide housing and housing services to people who need it. I encourage everybody to go out there and get involved with the Bring Chicago Home campaign, because it is something that we desperately need, and it is deeply tied to the work that we are trying to do with treatment, not trauma.
Okay, so our first question states, I am wondering if anyone knows the status of the 24-hour crisis center that Cook County Health established in 2016 in Roseland. The goal of the center was to provide 24/7 intervention and stabilization services for individuals who are at risk of detention or hospitalization due to a mental health or substance abuse condition.
I know about it, but
We don't know what
Okay. Okay, I'll go to the next one. It says the police budget is going from 1.9 billion to 1.99 billion, almost 2 billion out of a $16.5 billion budget. Is any of that going to or should go to more 911 mental health trained response teams. Would that be a good idea? This question is for any of the panelists.
I can't take that unless you want to talk about it.
You start off alone.
So part of the proposal for treatment of trauma was to turn police vacancies. We carry thousands of vacancies every year in the police department, and those vacancies cannot be filled at a rate that will allow you to actually have turn them into police positions that are out on the streets. That's just not real. There's also attrition. So you will be filling out positions, and then there are positions that continue to get vacant. So there's no way for the Chicago Police Department to catch up. So one of our proposals was to turn a few hundred vacancies from the Chicago Police Department and transfer them into the Department of Public Health so that we could actually create the community health worker corps. And we could staff up the mental health centers. We haven't gotten there yet. We are in a very difficult moment politically, I would say, in the city. We did win the mayoral seat in a progressive platform, but that doesn't mean that the right has gone away. That doesn't mean that the right is not on the rise and it's trying to fight all of the progressive ideas that we're bringing. So it is our intention to get there. It is our intention to continue to fight for those positions to be transferred to the Department of Public Health, but we are definitely not there yet.
I wanted to piggyback off the question that I don't know who posted online about like the police budget. I know because I have a sibling who had mental she had mental health episodes from time to time. And so I went to NAMI to learn about like training about like what do I do when this means, because at first it was like, you know, you're gonna start yelling at me, I'm gonna yell at you. And that doesn't work well at all. And so this is, it was there that I learned that if it escalates past me, that we can call and request for, I don't know if it's a CTI or CIT trained police officers. With all the work that you all are doing, which I think is very progressive and can help in the meantime, you know, is there any way we can see how many police officers are with whatever district or precinct, or how many of them are trained, or even increase the number of them in the meantime? Because it's nice to have these things available and to be thinking about these things, but if we still have people who are like ignorant or not well trained, these problems will continue to be deadly for all people of color.
Yeah, thank you for that question. You know, it's unfortunate. You know, some of the challenges that we've seen is nonprofits also have a very clear conflict of interest. NAMI Chicago receives millions of dollars to train police officers in the CIT trained model. That CIT trained model, unfortunately, the research clearly shows that does not have any difference in impacts of people's experience of harm by police. CIT trained officers like Derek Chauvin, the man who killed George Floyd, was a CIT trained officer. So it's unfortunately a lot of window dressing that is being done by selling CIT as a solution. Because again, the power dynamic, and we've heard this unfortunately from police themselves, is very clear. They are going to not hesitate at the pose of danger, at the assessment of danger, to subdue the individual by any means necessary. And yes, and unfortunately, what we've seen, it's only a 40-hour training that is on a voluntary basis. It's not a requirement, and it's many cases people are being sent to this training to just pad the numbers to make the department seem different than it actually is. And again, the data doesn't show that the outcomes are any better by CIT trained officers when it comes to responding to mental health crisis. And again, as Dr. Bocanegra mentioned, right, removing police from the situation is the safest way for everybody involved when it comes to mental health crisis. And again, there's research that we are partnering with other colleagues here in criminology and others who are assessing what crisis response looks like and why, unfortunately, the system that we are having to navigate today requires people to call 911 for help. And unfortunately, that often then requires police to show up and escalate, unfortunately, situations that could very much be de-escalated by people. if we had more time, I'd show a video of body cam footage, for example, in New York City that showed a woman who, so New York City was trying a pilot program in which they were establishing this co-response model where a police officer was responding with paramedics to tend to mental health crises. If I would show you the body cam footage right now, you see the police officer, a CIT trained police officer, no doubt, grab his hog tie, like those plastic wraps, the zip ties, correct, yes. As the woman is explaining why her son needs to be seen by a paramedic, not a police officer, that woman is subsequently arrested and spent the night in jail for trying to get a paramedic to respond to it by a police officer who's CIT trained. New York City then instead opted to expand the non-police crisis team citywide. So New York City is doing it. Chicago could do it as well. And for us, it's just as Alderwoman mentioned, we have a police department is ordering $2 billion of budget and is also hoarding money in these vacancies that could very quickly be implemented to scale up crisis response. And so we are very much encouraged by the creation of a working group. And this administration has been seeking to carry out the promise of treatment without trauma by first reopening 2 public mental health centers in this year's budget. And also, again, creating this working group so we could start thinking about how quickly and how robustly we need to scale up crisis response in Chicago to fill a void. I just don't want to lose sight of the questions. These are very great questions. And they all seem like isolated questions that are very much disconnected. But the very same policymakers who are giving away public land, like up the street, the Chicago Fire billionaire just was granted 40 acres of public land that was meant for public housing that could address housing in Chicago, was the same mayor who was now opening the public mental health centers, was the same mayor who's giving NAMI Chicago millions of dollars to train police officers to change the image of the public perception of police, who is also the same mayor who carried forward the same policies of Rahm Emanuel. So again, we're in a moment that is very much exciting, but being very sober in analysis, it's going to take a lot to turn this ship in a new direction because of, unfortunately, the inertia and just how much the legacy of neoliberal policies has shaped the city to the crises that we're dealing with today. So the issues of homelessness, the issues of policing, the issues of poverty are very much interrelated, and it will take a very different policy for us to get to different lived realities for people here in Chicago.
We'll do one Zoom and one, we'll go back. Okay, this participant, not sure if I missed this. Is there information about how well utilized mental health centers are? There are many mental health professionals who favor community-based interventions over clinical services. How do you envision services provided at different settings?
Yeah, I'll answer that really quickly. Our research that we highlighted earlier, where we asked Chicagoans if they would want to seek out public mental health services at a public mental health center. I mean, we're very intentional in wording it absolutely clearly for people in the general public, because there's this kind of notion that, especially people who have a vested interest in keeping the investment in a private model, who received hundreds of thousands of dollars from the city to fund nonprofits, they'll say, well, the public mental health centers, right, they weren't that good to begin with. And so they'll say that, no, unfortunately, people don't want to go to the centers. But when we asked, and you had 90% of Chicagoans said, yes, absolutely. Our follow-up question was, do you know that the city of Chicago has 5 public mental health centers? 73% of respondents in our citywide survey did not know that the centers are actually in operation. Right. So one way of undercutting the public infrastructure is by not promoting it. The public mental health centers, up until 2 years ago, and this is, again, our inside-outside strategy, Alderwoman Rosana was very much a champion in city council, gaining the support of 27 aldermen to support a $10 million investment in reopening public mental health centers 2 years ago during the city budget, when the mayor was proposing an additional $20 million for the private sector. 27 aldermen, the majority of city council, supported reopening public mental health centers with a tiny, a minuscule $10 million investment with a $2 billion federal relief package. That was shut down. Previous Commissioner Allison Arwady, which we absolutely campaigned to be fired. And we were absolutely happy that this mayor took that very brave decision to fire an ineffective and a harmful public health commissioner. That same public health commissioner who is also responsible for public mental health centers, was chastising aldermen for even considering the possibility of reopening public mental health centers. It took this effort for us to finally expand the hours of operation of the public mental health centers. Public mental health centers had been intentionally closing at 4:30 p.m. every day, right? It took our efforts to finally in that concession that the mayor had to make to pass her city budget, to finally expand the public mental health centers to offer evening hours. Now they're open to 7:30 p.m. because of our efforts. For the first time ever, now they are also offering services to children and adolescents for the first time, right? This is I could go on and on. I mean, they did not have electronic medical records. They were purposely set up to fail. So when we have a new administration now investing in reopening public mental health centers, we are also now going to push for people to be made aware that public mental health centers are there to provide free services. And that will, of course, absolutely increase the demand for services. So for us, you know, it's going to be as much of a investment shift as much as it's going to have to be a cultural shift to get Chicagoans to, again, believe that we have public infrastructures of care that are there to benefit them. And we see that right now with the migrant crisis. It's exposing how much need for investment in care there is by both residents who are recently arrivals to those who've been here for generations, right? The same needs exist for all communities.
Can I add something to that? Another thing that I would add is that the public mental health centers, we don't have a website for them. You cannot go online and make an appointment for them. And this is, I think I have been yelling about this for 4 years. I have been asking the administration, I've been asking Matt Richards to please, it is not rocket science, create a landing page for the clinics with the possibility of scheduling online. It makes things so much easier for people. You can direct people to the website, and it's way friendlier. We haven't been able to get there, but it is part of how we keep people from being able to access this, because then you say, well, nobody uses them. Why are we going to invest in them if nobody's using them because they don't know that it's there? The other thing that I would say is that it takes forever to hire clinicians, to hire staffing for the public mental health centers. And I imagine that you all like go around Chicago and you see all of the billboards, like hiring police, like become a police officer, Why aren't we having the same urgency to hire care workers, to hire people that can take care of people? And it is absurd to me that you're gonna say, well, we can't find candidates. What do you mean you can't find candidates? We have so many people graduating from several different incredible schools in Chicago that graduate social workers. We have so much expertise in our communities with people that are peer support workers that have the lived experience to do this work. We have nurses. And for some reason, we can't find the people. And when we find them, it takes forever to hire. So all of those are factors that play into the clinics not being able to provide the care that they should be providing to our communities, and you know, and the stigma of the public service that doesn't work, right? And I promise you, we're trying so hard to make these clinics like the best place to get care in the whole city of Chicago.
And one last point, and just to wrap up, you know, the big difference also between nonprofit organizations and public mental health centers is that the public mental health centers are accountable to the public. Every third Monday of the month, everybody here is welcome to join the community mental health board meetings, where you can learn about the public mental health centers from the administrators and provide your feedback and provide input. And so historically, when Chicago had 19 public mental health centers, each one of them had their local advisory board. And each one of those local advisory boards that were represented at a citywide board. When the city closed those centers, that democracy also kind of withered away with it. So accountability, stakeholders, nonprofits helping shape the vision of why public mental health centers can be a safety net that really is needed in the community, and how those services can be tailored to that very community is part of the same design.
I think we have time for at least 2 more questions from the audience.
My name is Stephanie Torres, and I'm a assistant professor here at UIC and Psych, and I'm also a clinical psychologist. This discussion is really near and dear to my heart. I was telling Yvonne when this was being put together, my mom was a therapist at one of the clinics that was closed in 2013 at Logan Square. She was a bilingual clinician, and myself and her and basically my whole family did a lot of work with the mental health movement in Matt Ginsburg to really fight for the clinics to stay open. And so this is really awesome. I'm seeing this finally come to fruition. And I just wanted to comment that I think everything that you said is really true. And Mom and I have been texting, she's on too, about this. And basically the city has really set up these clinics to fail, right? With electronic medical records, there are directors who are directors of 3 different clinics at once, right? Which is absurd. And so it's really great to hear that it's not only about just reopening the clinics as they were, but really restructuring and making them successful and signing them up for success. So it's really great that you're here. And I guess my question is, I know that there's plans to reopen 2 of the mental health clinics in the budget. I'm curious if we have any information of where those are and plans for reopening clinics in specific areas, like what areas are we thinking of targeting? But thank you again, sorry.
Yeah, thank you for, and thank you for sharing it. I mean, also the disinvestment in public mental health centers, as was just mentioned, impacts the middle class. These are middle class jobs for women of color more often than not, right? Who can have, again, an opportunity to serve their community. This is a type of investment we want to see in our community to support and strengthen communities that have been disinvested. So thank you for bringing that. All we've been told, and I don't know if all the other women want to add, but is that the 2 centers that are to be reopened are going to be reopened in existing CDPH facilities in order to make this as quickly as possible. But the working group that is being established will recommend where further investment will be necessary.
Yes, what Arturo said. We, as Arturo said before, we passed a resolution to create a working group. This working group is going to have 2 different parts. One of them is the departments that are going to be conferring all of the relevant departments that need to be working collaboratively to be able to deliver the work. And then there is a community commission that is going to advise that working group. And that's the work that is going to determine where and how, and it's going to be an open process, so people will have a chance to, know what is it that we are deliberating.
Okay, this question says, wondering about how you envision integrating mental health in the Chicago public schools, primarily among students, but also keeping in mind families and staff.
So okay. When we first came into office in 2019, we were advocating for making sure that the public mental health centers were able to collaborate with CPS. At that point, we still didn't have services for young people in most of the mental health centers. Now we do. Thanks to all of the advocacy and all of the fight, we do, and there are always possibilities to do that. Of course, Chicago Public Schools is a sister agency of the city, and they have their own protocols when it comes to services. There are many Chicago Public Schools that have nonprofit clinics in their campuses and provide services there. They also have their own resources to provide counseling. And there are social workers as well. But I can definitely see a situation in which we get there to collaborate. But right now, because of how little resources we have, we're starting to build this. And in the future, I definitely can see a strong collaboration. Right now, we have five centers, and we are definitely trying to build on that and create the reality in which we can have that kind of collaboration.
Thank you so much. As someone who spent time in both prison and psych facilities, really concerned about kind of trauma-informed aspect of this, in particular, thinking about, we're not really talking about psych hospitals, but I feel like that's part of what happens when people get into mental health care, and then particularly those of us who are chronically suicidal getting placed on 5-day holds, monthly holds, based on that. And then a consistent part of mental health care is sexual violence by staff. And in terms of strip searches, pat downs, things like that. I'm wondering how you are imagining dealing with the fact that so much of treatment, using the language that we're using, treatment is trauma. And how do we do the work of training professionals, but also challenging the ways that we criminalize those of us who are mentally ill to not have to get treatment that is structured in the way that someone tells us it has to be like this, that you have to go to these facilities, you have to take this medication. If you don't do that, you're disciplined for breaking outside structures of the psych treatment system. So I'm wondering, I feel like from what I heard, there's only one person who identified as a consumer who's on the panel. How are those of us who are mentally ill shaping your work and making sure that consumers are implementing what you're doing?
So we have users of the public mental health centers as part of our working group, and they are definitely going to be a really important part of advising in how to provide that care. Another thing that I can say is that the way that we're envisioning the public mental health centers is not what we have right now. We are very aware that people need a lot of different things, that a lot of times when people go into crisis, they might need to eat, they might need to take a shower, they might need to go into a room and hang out for a little bit alone. They might benefit from playing a video game or sit with somebody and have a cup of tea. And the way that we want to create the care for people is for people to be able to have access to those things. If you need to do laundry, then you can do laundry in one of the public mental health centers. We want to make sure that we have the possibility of de-escalating and giving people exactly what they might need at that moment. Of course, the public mental health centers are not places where people would be hospitalized. But they are places where we want to be able to respond to the immediate needs of people and be able to develop a plan of care that is going to move away from what you are expressing, from the carceral nature of mental health. Do you want to say something else?
Yeah, thank you for sharing. I think too often when our society tells people to get help, we don't consider the fact that not everybody who is involved in the system is a good person, that these systems can also be traumatizing. And I think that's why it's important to have more people with lived experience involved, and not just involved in okay, you have a seat on this committee way, but in actual positions of decision-making power, because they understand what you're saying. So I haven't had that exact experience, but I remember having some really bad experiences accessing care that turned me off for a while to this, that I thought, okay, this is just like more trauma than treatment. And then later on, I had positive experiences that restored my faith in the system, but there's definitely needs to be an acknowledgement that not everybody who has asked for help, or not everybody who maybe they didn't ask for help, but that, there was some other way that they got there, had a positive experience, and there's a sense of betrayal. What did my friend used to call it? Was like med trauma. There's a sense of betrayal when the people who are supposed to be helping you are actually the ones inflicting the trauma or reinforcing whatever was there. So I think that there's definitely not been an acknowledgement from providers and the medical community of the trauma that exists. And there's there definitely has to be a reckoning at some point for these injustices and a change in the system that will come from really including not just consulting, but really including people, whatever you want, consumers or people with lived experience, whatever you want to call it, so that these systems are reformed to be more humane and to actually do the things that they say they're supposed to do. They're why they exist.
I mean, I first want to thank you for your self-disclosure and for the being vulnerable in the space of sharing your experiences. And I think like an issue too is that like the criminal legal system is entangled with the behavioral health system. So you have the Department of Corrections grants behavioral health providers, your probation department provides grants to behavioral health providers, parole does. And treatment noncompliance can become grounds for a violation of your parole, your probation, and literally like a pathway. We have specialized behavioral health, we have mental health court, we have drug court, not showing up to your court. I mean, all of there's an effort to make a space for people with behavioral health needs in the criminal legal system that I find actually just creates a conveyor belt. And so disentangling that and building up your systems of public care, I think is a much better route rather than funding carceral systems to provide behavioral health services. So I just want to not like just build on that as well. And thank you for what you highlighted is the entanglement of these two systems.
The last thing I'll add is as a social worker, I've seen firsthand the harm and accompanying people through those institutionalization processes that are dehumanizing, that are harmful, that are traumatizing absolutely is what brings me into this work, right? Can we create a space and a system of care that can prevent and engage with people prior to crises? This is the goal of our campaign is to I remember when Rosana reached out, she's like, hey, check out this thing called Cahoots. And I was like, well, what are you talking about, right? It's like, it's this program and it's in Eugene. And the more we researched that, everything in that model was about the individual that they were responding to. Nothing that they ever provided individuals was not done with 100% full consent of the person who is engaging with those workers. That for me, in Chicago should be absolutely the same principle, right? Everything should be done with 100% consent of the individual who is being responded to by these care workers. So, and that may take multiple visits and building rapport and building and, allowing the space for people to, again, believe that care can be provided by a public workforce. So like, this is going to take time. But as a social worker, I envision, and why I'm so committed to this is to create those spaces of healing that are not punitive. And again, make that part of our social fabric in the way that these harmful systems already are. And I think that's something that for me keeps me in this space advocating. So absolutely, we want these working groups to provide. And we have, I just also finish by saying everyone here can also take space in public comment at our meetings. That's been one of our most powerful tools to get to legislators is to stack public comment and have people's testimony like yours and others. If you look at our June hearing, we had our public health hearing where we brought forward experts and we're able to discuss this in the health committee. This is our chairwoman's first health committee meeting where she brought in experts from around the country, locally. If you hear the public comment section, I mean, it gives me goosebumps right now to think about the power of people giving their voice and their experience to shape the conversation in halls of power. So please, as consumers, as people, as family members, as social workers and professionals, we can provide our own voices and accompany others to provide theirs in these spaces. It does make a difference.
Please join me in giving applause. This conversation is so timely. So please give yourself a round of applause. I want to thank you all for coming, for your questions, for you all are here, for the people who are on Zoom, thank you for coming. I also want to thank IRRPP and all the co-sponsors for this event. And with that, I wish you all a great night.